Welcome again, our colleague. This is pure GIT MRI containing very good and nice cases, most of them related to Viva and maybe long reporting exam. Please concentrate. Uh, Please, if you have any doubt or any question, discuss me or write in the chat box. Doctor, this is 50-year-old male patient with incidental finding of multiple hepatic lesion during coronary CT angio. Go on.
Okay. Okay, this is CT axial cuts. I can see there is multiple small hypodense lesions seen
Yes.
in both right and left hepatic loops.
Yes.
Uh,
Yes.
yeah. Uh, so yeah.
Yes.
Someone the mic is on for someone.
Yes. Yes. I mute on. Go on.
Yeah. Okay. So there's multiple irregular hypodense lesions seen in both hepatic loops. They are variable in size, but mostly small in size. Uh, yeah.
Yes.
Um, yeah. So for these lesions, I would like to ask for MRI for further characterization and ask about if the patient have any history of non-primary lesion. Because in this multiple hypodense lesions in the liver, if the patient is non-primary, I would suspect this might be metastatic liver
Okay.
lesions.
Very nice. I was about to ask why you are requesting MRI. Okay.
Yeah.
Doctor, do you need MRI with contrast or without?
With contrast mainly for metastasis, if I'm suspecting metastasis, to see the enhancement of the lesions, the pattern of enhancement.
Great. 1 second. I will show you the MRI. This is MRI. Look. This is T2.
Okay. This is T2 axial cuts for MRI, which confirms that there is multiple uh, um, isoechoic to high iso intense to high intense multiple hepatic lesions scattered all over the
Hey,
both
doctor,
hepatic loops.
doctor,
Uh,
not isoechoic.
yes.
In
Yeah. High.
MRI,
Sorry. Like
in
high
MRI, we use
intense.
intense.
Iso intense.
What is this sequence?
This is T2.
Excellent. What is the signal intensity of these lesions?
This is high intense. Iso
Okay,
to high
so no,
intense.
no ISO, no ISO at all. At least if you compare it with
Okay.
the
High
parenchyma, it is high. Okay, if you compare
with
with
the
the
liver. High intense. Yeah.
muscle, it is so high. This is so high, not just high.
Mm,
Okay, this is not fluid.
okay.
Fluid is another entity, but this is high.
Yeah. No.
What else?
This is high signals. Yeah.
What's your differential?
Um. I still have metastasis as in my differentials, but I would like to see the pattern of enhancement. I would like to see the arterial and the portovenous. This is the arterial phase, which this is early arterial phase. No definite enhancement noted, or maybe there
Okay.
is peripheral, just peripheral.
No, this is
In
this is the vessel. This is the liver parenchyma vessel, normal vessel.
Okay. Okay, so there is no definite enhancement noted for in these lesions
Doctor,
in the
look
arterial
here.
phase.
I will help you because this is
Yeah.
very difficult case. Look here and here. What happened? By the way, this is the
The,
maximum.
the vessel that is
Yes.
seen crossing within the lesions.
What does it mean?
So the lesion is, this means that the lesion is not aggressive invading the vessels.
Brilliant. What other sequence do you want?
I want the portovenous and the delayed.
I will help you. Look here. What is this? What is the name of this
Okay.
sequence?
This is the in phase and out of phase,
Excellent. What is this? This is in or out of phase?
and this is in phase
This one.
with drop of signal
So,
out of phase.
what do you think?
There is drop of signal, so this means that this lesion has a fat component.
Not has a fat component. All of this is fat component.
It's fatty. It's fatty. Yeah, it's fatty lesion. So, okay. So, this
So,
in this is not metastasis. This is rule out metastasis,
yes,
and this is fatty lesions. Sorry.
yes, yes. This is fatty lesion.
Yeah.
Give me a differential
Yeah.
diagnosis for fatty lesions.
Adenomas.
Adenomas in the liver.
Uh,
Okay, but there are
is
very, very simple diagnosis and very
uh
common. But
um
Dr. Nashwa, adenomas
yes.
not show this non-enhancement.
Yeah. Adenoma will be enhancing. Yeah.
Mhm. So, what else? Do you
Mm,
agree with me? It may be just fat deposition. Fat, 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 fat.
yeah.
Okay, give me
Yeah.
a
This is fat.
term. Give me the term. What is the term? Multiple focal.
Multiple focal fatty infiltrations.
Great. Thank you, Dr. Nashwa. You did very well. You were very logic, but you forget T1. My colleagues, T1 is very
Mm,
essential, especially when you are seeing a lesion, you should at least exclude hemorrhage or being fat. See, I will give you very good tips here. Look here, my colleagues. Despite
mm,
the large number of these lesions, no mass effect. Actually, look at the vessel here. Each vessel, look here. Each vessel is respected so much. So you should concern. You should think. You should tell the examiner it may be benign. Maybe. Why? Because no surrounding edema, no mass effect, and it respects the anatomy. Look here, my colleague, please mute yourself. My colleagues, mute yourselves. Very important sign. Very important. Okay? Don't be afraid that I may tell the examiner it may be benign and finally the final diagnosis may be malignant. No, show your examiner what is in your mind. As there are, look here, my colleague, as there are no mass effect and there are very great restriction for the anatomy, it may be a benign. Okay. Number two, look this one.
mm,
Look this one. This is very characteristic to focal fat infiltration. When you see a lesion that yeah, the artery traversing this lesion, this is pathognomonic. Very important. Very important. Okay? The only lesion in the liver that you can see, my colleague, the only lesion that you can see the vessel traversing it is the focal fatty infiltration. Okay, very important. So differential from the beginning were myths, and after MRI, it became another thing. This is T1. out of phase and in phase. How could we differentiate? Here it is very easy. Why? Because there are fat. So this is in phase and this is out phase. But if we didn't have any fatty lesion, it may be struggling for some people. I will give you very simple trick. Look at the periphery. This is the Indian ink sign.
India.
It's very black, very black, very black, very black. You feel like, do you remember when you are kids, the Tom and Jerry and the Mickey Mouse? You feel like this really. This is my opinion. Out of face, you feel like this is not the true image. But look here, this is the true MRI that we are familiar to us. Look here, it looks like cartoon film of our childhood. This is, I know this may be simple, but really, you will not miss it. Look here, if you want it scientifically, search for this Indian ink. By the way, Doctor, what is the name of this phenomena? Or why this
Chemical chemical shift.
chemical shift?
Chemical shift.
What is chemical shift?
Um,
What is chemical
I,
shift? I will
I
help you.
can't
What is
I
this?
can't remember it now.
What is
This
this?
is fat.
True. What is this?
It's
Cells.
soft tissue level.
Hepatocyte.
Yeah.
Hepatocyte
Mm,
mainly contain water, correct?
yeah.
So the interface between fat and water, this chemical shift occur between the interface between fat and water. This is the stomach. Look, this is the stomach. This I think you will be very clear here. This is a stomach filled of water. This is fat. So there are chemical shift. Why? This is originally this chemical shift يعني physically, so by physics, by MRI physics, the machine couldn't predict well the signal at this interface. The machine confused. Really, I'm not joking. This is the real physics, MRI physics. The machine here, these voxels, during acquisition, the machine confused. The machine don't know is this fat or water, so it represents this area by dark line. Okay, this is chemical shift giving the dark Indian or black Indian sign, a black Indian ink sign. Thank you, doctor, so much. Also, take care in the suprarenal.
Thank you, doctor.
I have been presented with case. It was only static film. The examiner give me out and in phase. And there are multiple small foci here in the kidney. One image, multiple image in one slice. One image uh, out and one image in. Okay, and you should detect there are multiple angiomyolipoma, and you should talk about tuberous sclerosis. Okay, by the way, يعني. Okay. So take care from my colleague from in and out of phase MRI in the abdomen. Okay, number one about the angiomyolipoma. Number two about the suprarenal, either adenoma or metastasis. Okay, number three, this case, focal fatty infiltration. So at least now, number four, but in the pelvis, about the dermoid cyst. So MRI. But by the way, Doctor, sorry, last question. What
Yes,
is
doctor. Yeah.
the value, the difference? See, in stir and out of phase, both of them suppress the fat. Are you agree with me?
Mm,
But what is the difference?
yes. The stir suppress the macroscopic fat.
Brilliant.
The in phase out of phase suppress the microscopic fat.
Thank you, Dr. Nashwa, so much. Today, you are in the top. Thank
Thank
you.
you, doctor.
Thank you, really. My
Thank you,
colleagues,
doctor. Thank you.
suppressed macroscopic fat. Okay, macroscopic. But in and out of phase microscopic fat. Very big difference. Very big. And by the way, this is very important question in the exam. Okay, my colleagues, I think I cover most of the question related to this case and related to fat SAT sequences. Thank you. What is the evidence of the out of phase only suppressed macroscopic fat? Last question, Dr. Nash. If you give me an evidence from
Yes, doctor.
Dr. Nagam will give you 10 sterling. 10 only. Mm. Give me an evidence.
Sorry, what's your question again?
What give me from this image
Evidence that
evidence that out T1 out of
yeah,
the suppress only microscopic
the,
fat.
uh, the subcutaneous fat is still bright,
Brilliant, Dr. Nagam.
and the intra-abdominal fat.
Excellent. Look here, my colleagues, subcutaneous and the intra-abdominal fat are macroscopic, not suppressed. Look.
Mm.
So not suppressed in comparison to the fat here. Okay, my colleagues, thank you very much, Dr. Nash.
Thank you.
Next, okay, next candidate.
Yes, sir. Assalamualaikum.
Alaikum salam. Doctor, this is 65-year-old female patient presented with painless jaundice.
All right. I'm presented with corneal MRI images of abdomen, T2-weighted sequence. On the first
Could
look,
you
I can
request
see that there
control?
is,
Doctor, can
yes,
you request control, please?
yes. Okay. Yes, I did.
Go on.
Okay. Oh, yes, I'm able to scroll now. So, on this corneal image of T2-weighted um, sequence, I can see that there is marked dilatation of the there is mild dilatation of the gallbladder, and which is seen filled with the multiple hypointense rounded structures representing calculi in the region of the gallbladder. As I go up, I can see that there is also multiple calculi noted in the region of the hepatic hilum,
What else?
which is likely in the CBD. Some hypointensities are also I'm trying to locate the CBD. I do not see any dilatation of the intrahepatic biliary channels.
Are you sure? Look here. 1 second. Look
There
here.
is mild
Look
dilatation.
here. Look here.
Yes. Oh, yes, on the X.
Hmm.
Yes, there is dilatation of the intrahepatic biliary channels, mainly the right and left hepatic ducts.
Mm-hmm.
Um, some of them show the areas of dilatation, and at the here at the confluence, this is CBD and this is the portal vein.
Don't worry about it.
Mm,
What happened?
okay. There is increased areas of increased signal intensity noted in the region of the confluence of the right and left hepatic ducts, and stone is also seen in the region of cystic duct and CBD also.
No. No stone in the CBD. And
Okay.
see, there are intrahepatic dilatation. And most of the CBD is
Yes,
dilated.
over here. Yes.
Please follow the CBD.
Yeah. All right, I can see that there is a soft tissue intensity lesion seen in the
Excellent.
ampullary periampullary region,
Excellent.
which is seen causing the abrupt cutoff, and above it there is dilatation of the CBD
Excellent. Where is this thickening?
over here.
Which
Thickening is on this slice. There here. Uh, I think there is mild. Here, here, over here. There's mild thickening, luminal narrowing.
what's your diagnosis?
This soft tissue thickening is concerning for any malignancy in an elderly patient, which is causing retrograde dilatation of the CBD, main CBD, and also of the intrahepatic biliary ducts. So I will correlate with the previous imaging if available, and also will advise a gastrointestinal referral for ERCP and biopsy
Okay.
and MDT discussion.
Okay. See, I will help you. Look at the second part of the duodenum. What is this? By the way, it is very
Thickening.
difficult case, but you be at least you pick up something. What is this?
This is thickening along the second part of duodenum and in
Yes.
between the pancreas and the second part of duodenum.
Yes. See what happened? This is the second part. By the way, see my colleague how to detect duodenum, and you be sure, you are very sure. This is the gastroesophageal junction. Follow it, please. Stomach. Follow, follow. Okay. This pylorus, this is first part of the duodenum.
Yeah.
Okay.
First
And
part of
then this is the second part.
second part.
Okay. Here.
Yes. Okay.
Here, see, there are sessile thickening. By the way, to be fair, this case should be shown in contrast. Okay, and in axial and coronal. Even here, not clear. I tried many times. Okay, it may be this one. No, this is the first part, maybe, but better to be examined in all plans post contrast. Anyway, and the diffusion, by the way. Anyway, at least, thank you, doctor, so much. What is your next step?
Next step would be ERCP and relief of the obstruction by the ERCP and stent placement.
Excellent. ARCB done here. Look, this is the ERCB, and they both stent. This is the ARCB. This is BTC, I think, from the beginning. This is BTC. Okay. I think the catheter
Yeah.
from outside here. Yes, this is BTC. Okay. And
Okay.
I think there are. See, this is guide wire. They insert something. They open the obstruction, and the contrast go to the duodenum. This is PTC. Why the catheter came from here, from the
Yes.
skin. So the most important part and the most difficult part in this case is that multiple innumerable stone are so confusing. So most of
Yes.
us are thinking, sure, not thinking, is this Merezi syndrome? Is this acute cholecystitis? Is this CBD stone?
Corridor,
Okay,
yeah.
very distractive case, very confusing. But anyway, take care. In Viva, they like to distract you at least in one case. Okay, my colleague. Thank you, doctor, so
Yes.
much. The second,
Thank
my
you, doctor.
colleague, again, see. This is the sickening here. Okay. Thank you so much. Sickening of second part of the duodenum. I think here the pancreatic duct not so much dilated, just the distal part here. We must measure it. Thank you so much. Next candidate. Next candidate.
Hello.
Assalamualaikum.
Okay.
Hello. Are you ready, doctor?
Assalamualaikum.
Alaikum salam.
Yes.
Request control, please.
Sorry, sir, I cannot request control as
No
I
problem.
am on mobile.
No problem. No problem. This patient is 25-year-old male patient with chronic diarrhea. Go on.
Okay, so this is the coronal images from MRI T2 weighted images, in which I can appreciate there is dilatation of the colon and diffuse dilatation of the colon noted with multiple hypointense areas.
Doctor, what is the name of this study?
MR enterography.
Yes. What else? Take care in MR enterography. What is the technique? They give
In MR,
Yeah.
sorry,
What is the patient take or drink?
low smaller, I think water.
Yes, yes. He take a lot of fluid, maybe mannitol, to distend the bowel. So don't
Yes, yes.
rush and diagnose bowel dilatation before you search and investigate all the study. Okay? By the way, the colon is normal.
Okay.
Don't worry about the colon. Yalla. Let's start again.
Okay, there is thickening of, I think, thickening of distal ileal loops
Yes.
with narrowing
Yes.
at ileocecal junction.
Yes.
Uh, Thickening of ileal loop narrowing at ileocecal junction.
Mhm.
I will look at the cecum, whether it is contracted or not. I cannot appreciate any enlarged lymph nodes. It can present Crohn disease.
Yes.
I will rule out the fistulas, abscesses, and other complications of the disease.
Okay.
Mm.
What is the next
Other
sequence?
differential possibility is tuberculosis.
Okay.
Next sequence, I will look at the DWI, which is um,
Which sequence do you want?
a post-contrast or DWI images.
Okay. I think this is second.
Okay, this is T2 weighted axial. This is ADC image. ADC.
What do you think?
Uh, yes, on ADC imaging, I think there
Not
is
EDC. Not EDC. Why? Look at the fluid.
DWI.
Could you detect the
Yes,
fluid
this is
here?
DWI imaging, in which there is a restriction.
Yes.
Yes, there is restriction noted in the previously mentioned iliac region.
Okay.
So I think this restricted diffusion shows that this is active inflammation.
Yes.
Uh, yes, the restricted diffusion shows that this is active inflammation. I will rule out the other complications in the study to rule out any fistulas formation or abscesses formation. So
Okay,
this is
doctor.
the synostix.
Is this one second? Is this long segment or short segment?
This is long segment.
Is this skipped lesion or not?
Yes, skipped lesion. I can appreciate other lesions as well in the mid abdomen, iliac lobe.
What happened here? What is this?
I think these are abscess ulcers.
No. See, this is the lumen. This is extraluminal. What is
Feature,
it? Huh?
featureless lumen.
No, this is outside.
This okay. These are vasa recta, congestion of engorged vessels. Comb
What is
sign.
the name of this congestion?
Comb sign, engorged vasa recta.
Excellent. Comb sign. Okay, so give me a conclusion, please.
Findings are suggestive of active phase of fibrostenotic Crohn disease.
Okay.
I think there is also fatty proliferation in the
Okay.
mesentery with multiple skip lesions. So I will refer
Okay,
the patient to
what is this?
gastroenterology team.
Okay, what is this?
I think these are small ulcers.
Again, ulcer or something else?
Fistula.
Maybe. Maybe this is fistula. In my opinion, it may be fistula. Regiopedia didn't comment at all at this, but really, my colleague, the fistula looks like typically like this, and we detect in coronal, especially in post contrast and T2. Okay, so conclude, doctor.
Oh. This is the fibrostenotic Crohn disease with active phase, resulting in multiple fistulas formation and engorged vessels. So I will refer the case to gastroenterology team for further management of this case and follow-up
Do you know the most
imaging.
recent classification for Crohn's other than active or chronic or non-active?
Fatty proliferation or stenotic
No,
phase like this.
no. Anyone knows the most recent classification? Anyone? Okay, penetrating or penetrating or non-penetrating. Okay, penetrating fistula. There are grading system. I don't know really, but the most recent classification may be either this there are fistulas or not, so they call it penetrating Crohn's or non-penetrating. Okay, but the most well known for
Oh,
most of us is this active or chronic non-active. Thank you, doctor, so much. Take care, my colleague.
okay.
When you presented with MRE or MR interrography, number one, exclude inflammatory bowel. Common is common. Number two, look to the stomach and the duodenum to roll the scleroderma. I am trying to, especially in here in axial, especially I look at the stomach. Okay, this is the stomach, and then to the duodenum and to the fold here. This is acceptable. Okay, if you see all of this is dilated, thick wall and thick fold. Okay, so think in scleroderma. Number three, think about masses or cancers or diverticulitis. Okay, my colleague, MR enterography. The patient take a lot of fluid, whatever the amount. I think from 1.5 to 2 liter, and some osmotic material with it to shift the fluid into the bowel to distend it. Some preparation, maybe some Buscopan also to avoid contractures, sorry, not contractions, spasms. Okay, take a general, يعني a general data about the preparation, but the most important, when you see a case like this, think in inflammatory bowel. First inflammatory bowel, and look here at the right iliac fossa. The key is here. Okay, my colleagues, thank you, doctor, so much. It was a case of active Crohn's disease. Next candidate.
Yes, sir.
Doctor, this is 15-year-old male patient presented with abdominal pain and altered bowel habit. Could you request control, please?
Yes, sir, I requested.
1 second, because there are many annotation. Request, please. Hello, doctor.
Yes, sir, I requested.
Okay,
Sir, I requested.
go on. 15-year-old male patient presented with altered bowel habit. Go on.
Sir, actually, I'm not able to. So,
1 second, doctor. 1 second. 1 second. This is the same patient. Yes, I will help you. Go on.
okay. So this is MR abdomen, T2 weighted images, and I can see that stomach and bowel appear grossly unremarkable. Liver appears unremarkable. The gallbladder is normally distended.
What happened? Yes. See, I will help. I will help you.
Yeah.
Look here. What happened?
Okay. This is a diffusion weighted imaging, and I can see that there is a diffusion restriction in right iliac fossa and mid-abdomen. There are multiple nodes and mesenteric nodes, and I can see that there are, so these are likely the mesenteric nodes which are inflamed.
Yes.
Cecum is also showing restriction.
No,
So can you scroll a bit?
Don't worry. Do you think this like this?
No.
So what's
not
your
like
final
this.
diagnosis?
So this could be a case of mesenteric adenitis.
Excellent. What will you do next?
So mesenteric adenitis is a self-limiting condition. I will ask the history of any previous viral infection.
Yes.
Yeah.
Okay, doctor, thank you. See, my colleague, one of the most important function for diffusion to detect lymph nodes. Really, if you see here T1 and T2, you can hardly see the nodes. Okay? Very not clear
Now I can see.
like diffusion.
Yeah.
Okay. Sure, we will confirm on EDC. Look here. Okay, low EDC value. Look here, doctor, to the doc. This is facilitated. So I told you, don't worry about it. Thank you so much. The value of this case to train your eye about the lymph nodes. multiple restriction here, multiple restriction, diffusion of the fusion weighted image in the expected location of the lymph node. Follow it one by one. See, prevascular. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Alaikum salam. Doctor, this is 30-year-old female patient with right lower abdominal pain. Look here.
Right, sir. Okay, sir, I'm presented with the MRI of a 30-year-old female who presents with
Scroll.
a right lower abdominal pain. So this is a T1 weighted image.
Are you sure?
I'm going. So let me see the spine, then I'll orient myself. So I'm scrolling from the bottom towards the top, and I can see that this is T2 weighted image because the bladder is of high signal intensity.
What happened?
So I can see that there is some thickening noted in the wall of the sigmoid colon.
Yes.
I'll take a quick look to the top images and then make my comments. I can see the ileocecal junction is intact and the normal fatty area in the ileocecal junction is preserved.
Yes.
So I'm going further top to see if any other abnormality is evident on the scan. So I think this is only the pelvis MRI included.
No problem. What
in
happened?
These cards.
The
Okay.
cache is
So
here.
can I have the? Okay. So I see that this abnormality is arising from the most distal large gut involving the sigmoid colon in a continuous fashion. And this includes thickening of the sigmoid colon and pericolonic fat stranding.
Stop here. Stop
I
here.
do not see any significant.
Stop here, doctor. What happened? Tell me.
So could this be a case of early ulcerative colitis?
1
I
second.
also see some.
Doctor, 1 second. Look here. What happened here? Tell me.
There in the colon? You're asking about the colon?
No, I'm asking about the whole image. What happened here? I will scroll.
So there's also an abnormal
Yes.
signal intensity area within the right hemipelvis.
Excellent. Okay.
This area.
Yes. What is this? Is this mass collection?
So because this is T2 weighted image, so some areas are cystic and some areas are solid. So can I have an axial contrast enhanced image of this patient?
Go on.
Okay, so let me scroll. So I can see that there are definitely some contrast enhancement noted in the right axial region. Considering young age and with such findings, I'm thinking if this could be a case of tubo-ovarian abscess in this region because there are very inflammatory adenitis changes
Okay, what else?
noted in this region.
Okay, what else? What else?
Okay, sir, is the T1 non-enhanced available?
See, doctor, I will help you. You are correct. There are inflammatory collection. But look here. What happened? Look. This
So the
right,
T1,
this right adnexial inflammatory collection or abscess have two possibilities. You informed me with one, tube ovarian abscess. What is the other possibility?
yes.
What is this?
So
What
let
you,
me see its connection with the cecum.
yes? Is this
So the
connected?
ileocecal junction was intact, but this is because this is going towards the right iliac fossa and towards the cecum. I'm thinking this can be a case of acute appendicitis if the inflammatory markers are raised and there is
Yes, raised.
intense enhancement and collection. So this can be a case of acute appendicitis because in this location there are two possibilities.
Only
Either
appendicitis?
adnexal pathology
Only appendicitis?
with periappendiceal abscess.
Yes. So this is local abscess here. There are a perforation.
Yes.
What will you do next?
Okay. So in this case, urgent surgical referral is indicated, or maybe some drain can be placed if there is abscess collection.
I think I'm not expert in
But since
intervention.
if this is perforation, I think this
Yes.
requires emergency
Yeah.
surgical referral.
Yes, it needs a surgical decision rather than interventional because it is perforated and there are localized abscess. Look, my colleagues, thank you, doctor, so much. Very nice case. Why?
Thank you.
Look here. This is a collection here. Leave the mouse, please. And this collection, look here. This collection connected to the cecum. How could we detect the appendix? Look, go from to be easy, very easy. This is the ascending column. Follow it downward, down, till you see the ileocecal junction. Where is the ileocecal junction? This one. This one. Look posterior to it. Posterior. The collection, what is seen, the collection extended to the expected site of the appendix. At least, despite this is the appendix, by the way. But at least the collection replacing the appendix. Okay? So this is perforated appendix. Okay?
Right.
Actually, this is the appendix and there are a defect. Okay? I think the defect is here. Anyway, if you told the examiner, even if you give him this is tubo-ovarian abscess versus more likely appendicitis, he will be very happy. Why? The message, you are running in the correct pathway of a surgical decision, of an emergency. Why this emergency, doctor, in your opinion?
So because if the appendix is ruptured, this can result in fecal peritonitis and serious
Brilliant.
complications.
Yes, fecal peritonitis is the most common. Thank you, doctor, so much. Or diffuse septic peritonitis. This abscess may extend in all the appendix. In first of the early my specialty, I saw one young girl, it was 14-year-old, with large pelvic abscess, and they were thinking, what about the origin? It was, by the way, in my country, where they were wondering from where this abscess, from where. I told them, did you check the appendix? Let's check the appendix. No appendix at all. This is rupture appendix. Okay, but large, it was huge abscess in the pelvis. Thank you, doctor, so much. Next candidate.
Thank you.
Assalamu alaikum, sir.
Leave the mouse, leave. Doctor, alaikum salam. This is 70-year-old male patient presented with abdominal pain. Go on.
Okay, sir. These are Excel slides, coronal slices of MRI abdomen, T2 weighted images. I'm unable to scroll.
1 second. 1 second.
yeah.
Scroll.
Okay. Yes. No. Sir, still okay. Is that you scrolling, sir?
Use arrow, use arrow.
Okay. Okay, these are coronal slices of MRI abdomen, T2 weighted images, in which I can appreciate that there is a lesion noted in the stomach that is ISO to hypointense, and on this T2 weighted image, this is a well-defined area that is iso-intense, and no other, however, there is no obstruction, and the bowel loops distal to it appear normal, and I would like to see it on any other imaging sequence as well. It is very well defined and projecting within the lumen of the stomach.
Yes.
And, next, I would like to have a look at post-contrast images.
This is the post-contrast. Look, go on.
Okay. Okay, these are the Excel slices and T1 weighted arterial phase images, in which I can see that it appears iso-intense, and it it does not show any post-contrast enhancement, and the stomach wall also appears
Are you sure? 1 second.
normal.
No. It shows
Sir,
some.
there is some thickening here,
See.
nodular thickening. Yeah.
See, 1 second. To be sure, leave the mouse. We must compare with the pre-contrast.
Yeah.
Okay, this is very
Okay, sir.
important,
Yes.
by the way.
Yeah.
I don't know not all.
Yeah.
Okay, where is the pre-contrast here? No pre-contrast. Okay, and second, look here. It looks like similar to
Yeah.
the enhancement here of this one of the liver.
Yes.
I think it takes some enhancement.
Okay.
Heterogeneous. Okay, what's your differential diagnosis?
Okay. Sir, it can be any, sir, as it is very well defined, and it has obtuse angles with the wall of the stomach,
Okay.
and it may be any benign. It seems to be like any benign lesion, and most likely any leiomyoma of the gastric wall,
What else?
and other possibilities can be GIST. That is GIST,
Okay.
obviously, and other possibility can be any. Does the location of this lesion moves, or with the change in position of the patient? Then it can be even, but it doesn't look like any basal.
What do you mean by
And
GIST? What do you mean by GIST?
sir, gastrointestinal stromal tumor.
Okay, thank you,
That
doctor.
is most likely
Yes.
extra. Yeah.
As this page,
Okay.
as this endophytic and not small, large.
Yes.
Okay, and there are no obvious
Yes.
infiltration here, so we are away from cancer stone.
Yes.
Okay, looks like GIST. Sometimes
Yes.
the GIST may be exophytic. Sometimes it may have some ulceration,
Yes.
but no aggressive signs. This is GIST. One of the common site is the
Yes.
stomach. What is the most common
Yes.
other side of chest?
Sir, that is leiomyoma of the esophagus.
What?
Of the esophagus, I guess.
No, it's small bowel.
There we call it leiomyoma of the esophagus.
No, I'm talking about the chest. What is the other common site for chest? Is small bowel. I think especially
Okay.
the ileum, as I remember.
Okay.
So it is common
Yes.
in stomach and small bowel. Thank you, doctor, so much.
Okay.
Gastrointestinal
Thank you.
stromal disease. Leave the mouse. Next candidate.
Okay. Yes, sir.
Next candidate.
Yes, sir.
4 years old male patient presented with abdominal distension. Go on.
With pain. Okay, sir. Sir, I'm provided with the MRI T2 weighted images.
Okay.
Sir, just give me a second. Sir, I just want to scroll the entire stack. I could appreciate trace palatal pleural effusions and a large T2 bright lesion that is probably located within the liver, but I would like to confirm it on the coronal projection if possible. There is mass
No,
effect on the kidney which is displaced posteriorly.
no coronal image available. What do you think about this one?
Okay. Sir, I think it's in the lesion is in the liver and it's bright on T2. Sir, can I have a look at the T1 non-contrast and post-contrast sequences?
Okay, doctor, leave here, leave mouse. What is this?
Okay. Sir, I could appreciate that there is significant peripheral enhancement noted within this lesion with internal non-enhancing areas. Sir, just give me a second. I want to scroll this. The infrarenal aorta is of very small caliber. The suprarenal is of normal caliber, but the infrarenal aorta is
Doctor,
of very low caliber.
give
So
me
considering this, I'm thinking of
differential about
infantile,
this
sorry,
lesion.
sir, I'm thinking of infantile hemangioendothelioma, and
Okay.
I would like to correlate with the serum platelets level as there is peripheral enhancement and central non-enhancing area present.
Okay, what is this?
Sir, a T2 bright lesion. Sir, I could appreciate the certain flow voids, I think, present,
What? Oh,
low
what
areas
does it
likely.
mean?
Sir, there are low areas, they could represent calcifications or
Philippoli.
they could represent tiny calcific foci.
Philippoli. What
Sorry?
is your next? What is your next step?
Sir, sir, I would like to inform the primary of the finding as this large hemangiomas can cause Kazabit-Marett syndrome in which there is platelet sequestration and patient present with platelet deficiency. And I would like to take an PEDS IR consult,
The
PEDS
clinician,
surgery, I think.
the clinician wanted to confirm your diagnosis.
Okay, sir.
He wanted
Sir, I
to
think,
take biopsy. What is your response? What is your answer?
sir, I think we do not biopsy the hemangiomas.
Fatal. Fatal mistake. Yes,
Yes,
you
sir.
are correct.
Yes. Yes, sir.
Hemangioma, don't biopsy even a small
Biopsy.
hemangioma. What
Yes, sir.
other lesion that not should be biopsied in the abdomen? Give me two.
Sir, RCCs.
अच्छा हो गया वो पल्ला
RCT,
मेरी तो
Sorry.
हार्ट बीट 150
correct.
पे पहुंची हुई थी अब सबके वो सुनता है सुरहानिया कह रहे माशाल्लाह
Sir, I don't know. Someone's mic is unmuted.
No problem. She is so happy. This is very good for us.
Okay, sir.
RCC, what else? Something, two lesion at least.
Sir, RCCs should not be biopsied. Pheochromocytoma, adrenal.
Excellent. What else? Angiomyolipoma.
Angiomyolipomas, yeah.
Okay.
There's also a risk of bleeding.
Okay, excellent, doctor. So, uh, it may be, I think it may be treated by resection or by embolization, whatever, but no, no, no
Yes, sir.
biopsy. Fatal. Thank you, doctor.
Okay,
Take
sir.
care, my colleagues, from this signal voids. Very important. Where is T2? This one, signal voids. Okay. 1, 2, 3, 4.
Okay, sir.
Thank you, doctor, so much. Next candidate.
Yes, sir. Assalamualaikum, sir. Next.
Salam, request control, please.
Yes, sir. Mm. Okay,
Request,
sir.
yes.
Yes, sir. Okay, sir. Sir, history? Yes, sir.
Doctor, this patient presented with
Okay, sir.
recurrent,
11 year.
yeah,
Yes,
recurrent pleural effusion. Yeah, scroll.
yes, sir. Okay, sir. Sir, I'm provided with the T2 weighted images in which, yes. So there's okay, sir. Sir, in which I can appreciate there's a large pleural effusion on the left side, so it's not going up. Okay, sir. Okay, sir. Yes, scrolling from top to bottom. There's a large pleural effusion which is causing a mediastinal shift toward the right side, coming toward the abdomen. Stomach appears to be compressed. Sir, okay, sir. These image, liver appears to be fine.
Concentrate
There's
on
no
the effusion.
intrahepatic biliary
See,
duct
see,
dilatation.
this effusion is
Yes, sir.
recurrent despite multiple
Okay.
drainage. Why?
Hmm. Okay. But recurrent, sir, any cardiac abnormality which may leads to or
No,
renal abnormality?
no.
Um, Sir, also the pancreas, I think it seems to be little atrophic. I think 11-year age.
Okay, so you are right.
Mm. Oh,
What happened?
yes, sir. Okay, sir. Sir, pancreas is a little atrophic. Maybe, sir, cystic fibrosis may also have
See, doctor,
fatty.
this is not
Uh,
contrast. Doctor, this is T2.
okay, sir.
T2, I think fat set.
T2 will do.
So,
Yes, sir. Then,
what do you think?
Also, sir, ascites also there is also ascites.
Okay.
Okay, sir. Hmm. Kidneys are fine, sir. Sir, I think atrophic pancreas is there. I what abnormality. Sir,
Okay.
other images I can see more anatomy of the region. Yes, sir.
What else?
So gallbladder is normally distended. Duodenum is fine, sir. No any mass lesion is identified. The ascites also there.
Okay, doctor. See,
Sir,
what is the relation
yes, sir.
you told me about two pathology, pleural effusion and
Yes,
pancreatic.
sir.
I will help you.
Yes.
And pancreatic atrophy. Look, follow this, please.
Okay.
Follow.
Yes, sir.
Follow. See.
Yes, sir.
What is this?
Okay. Yes, sir. Sir, it is communicating with the pancreatic region. Maybe there is like
Yes.
chronic pancreatitis with pseudo pancreatic cyst. Yes, sir. Yes.
Yes. Follow. See. Follow
Yes,
this
sir.
one.
Yes, sir. Yes.
Follow.
Yes, sir. This is yes, sir. This yes.
Go down.
Yes, sir. This is
Down.
communicating to peripancreatic region.
Down.
Yes.
Go down again. There are
Yes, sir.
fistula tract. This one, yes.
Fistula spread.
So
Okay, sir.
the consultant asked for reconstruction. Look at this one.
Okay, sir. Yes, sir. So, yes, sir. So there is a communication of this pancreatic, this pleural effusion up to the peripancreatic region, and there's also
Okay,
atrophy
see,
of the pancreas. So this
I
is
am in
chronic
the
pancreatitis with
one second. I am in the exam and
pseudopancreatitis.
I am confused.
Yes, sir.
Let's show me one step by step. What is this?
The gallbladder.
Excellent. And this is, I think this is the duodenum.
Yes, sir.
What is this?
Second part, duodenum.
Okay,
Yes,
what
sir.
is this?
So it's a common hepatic duct.
Okay, what is this?
CBD, sir. Sorry, CBD.
Excellent. And this is the
Yes,
effusion.
sir. This is
What
yes,
is
sir,
this?
pancreatic effusion. Yes, sir.
What is this?
Yes, so that's, I think, stomach shadow, little of stomach
No,
shadow.
this is collection.
Yes,
Pseudocyst.
sir. So I think
Okay.
this is collect.
Okay.
Okay, sir.
And there are a connection. This
Yes.
is a connection between the effusion and the pseudocyst of the pancreas. See the pseudocyst connected by also the duct, the red duct. So
Duct, yes.
this is
Yes.
recurrent pleural effusion due to pancreatitis.
Pseudocyst formation due to chronic pancreatitis. Yes.
Okay, but there are still missing part. There are pancreatico-pleural fistula. Pancreatico-pleural fistula. Okay? How to confirm this fistula, doctor?
So we can give some contrast to this if this cavity which
Okay.
may
What
communicate
else?
within the effusion. We can this filogram.
What else?
Then I think if you give some contrast agent, it will communicate within the
Yes,
peripancreatic
What else?
collection.
What else?
Yes, sir. If you, what else? Sir, even we can aspirate
Excellent. And
on, not aspiration, but
yes, and
yes, sir.
analysis.
And it may show some pancreatic enzyme. Yes, sir.
Yes,
Pancreatic
lab
enzyme and
analysis.
pancreatic levels. Yes.
Thank
Yes,
you,
sir.
doctor, so much. Very fantastic case.
Sir.
So, my colleague, in all recurrent huge pleural effusion, check any defect here, check any connection with the pancreas or the colon. I think during our Viva, we show this case. This is the third time. Once it was pancreatico-pleural fistula, and the other one was colonic pleural fistula. Thank you, doctor. Next candidate.
Thank
Assalamu alaikum, sir.
Alaikum assalam. This is 20-year-old male patient presented with, he has trauma to the upper abdomen, I think. Go on.
Okay. Okay, sir. I'm presented with the non-contrast CT of a patient who presented with the history of trauma to the upper abdomen. First of all, I will scroll to the top and then start commenting. There are moderate bilateral pleural effusions are noted, and I would like to review the lungs on the lung window as well. Then as I scroll down, in the confinement of the non-contrast study, the spleen, visualized liver, kidneys, they appears to be unremarkable. And then, as I scroll down, the stomach is partially distended, and okay, so there is heterogeneity in this area is noted. Pancreas cannot be clearly visualized, which I would like to review on the post-contrast images as well. I cannot outline the boundaries of the pancreas. And then as I am scrolling, there is a heterogeneity and mesenteric standing noted in this region as well. And okay, so
Use the mouse, doctor, 1 second.
visualize bowel or fluid filled, and
What happened?
And so changes of fat standing are also noted in the okay.
Okay. What happened, Dr. Omir here?
Sir, here, okay. Sir, I'll scroll. So this is the pancreas, and then so this is some abnormal dilatation and stomach, and then I would follow the stomach into the duodenum. Okay, this is duodenum, and there is retroperitoneal fat stranding and heterogeneity can also be appreciated, and this structure
Dr.
is
Omir,
gallbladder.
what happened at the head of pancreas here? Head and neck. What is this?
Sir, head of pancreas.
What
So
is
this
this?
is ill-defined and the traumatic avulsion of the traumatic injury to the head of the pancreas.
Okay.
Because I cannot outline its boundaries and I cannot
Yes.
appreciate.
Is this cyst or pseudocyst?
The traumatic pseudocyst will take time to develop, and
We don't know since when this trauma. Just the
okay.
patient report. We don't know when. So,
Sir, I think there is some cyst which has connection with the adjacent duodenum, and sir, from here, if you follow this from here,
it
there is
has
some
a
cystic
connection,
structure.
Dr. Omer, it has a connection with another structure.
Yes,
Dr.
sir. Yes, sir.
What is this?
Okay, sir. This is pancreatic duct. Pancreatic duct is opening into. Sir, I lost the screen. Okay. So this is the common bile duct, and it is remarkable. And then that strict cystic structure, and it is connected uh, to the pancreatic duct and all opening into the duodenum. Here, sir.
Yes.
Second part of the duodenum.
What is
Sir,
the
here I
difference,
think.
Dr. Omer, what is the difference of between pseudocyst and cyst?
So pseudocyst has no walls, and cyst has and the cyst has epithelial lining and it has walls.
What?
Sir, the pseudocyst has got no walls. It is basically from the reaction from the surrounding tissue,
Okay.
and cyst has got epithelial lining wall.
Excellent. Excellent. How long it take to form this pseudocyst?
Sir, pseudocyst, sir, as far I remember, sir, 4 to 6 weeks at least.
Excellent. What is the management of pseudocyst?
Sir, pseudocysts usually are, sir, so first of all, the conservative management is tried, and then if they are not treatable, then cystostomy with the stomach or adjacent, they are open into the adjacent structure for drainage. Like if they are in the relation to the stomach, then a connection between the pseudocyst and the stomach can be made surgically, and so these can be drained.
Thank you, Dr. Omer, so much. It was post-pancreatic injury, pseudocyst formation connected, and this is very important, connected with the main duct. Why? It will change completely the management plan. I think they must repair this one, this area. Why? Because the pancreatic
Yes,
duct is oozing here. Whatever the
yes,
management, but we should mention about this connection. Thank you, doctor, so much. Last case,
thank you, sir.
because my colleague, I'm sometime take some sleeping naps between the cases. Next candidate.
Assalamu alaikum.
Salam, doctor. 60-year-old female patient complaining of fever.
I have been presented with axial abdomen CT scan for 60-year-old
No, not
female
CT.
patient with history of abdominal pain.
Not CT.
What?
This is MRI.
Yeah. This is MRI study. Yeah, this is MRI axial images T2 sequence. The first abnormality, I noticed that there is lobulated cystic lesion seen in the occupying most of the right liver lobe and showed heterogeneity. There is areas of hyperintensity and hypointensity seen within the mass lesion. I can see that there is which is like fluid level within this lesion. There is no intrahepatic biliary dilatation, and I can see that the liver surface appears smooth. There is no nodularity or irregularity. The mass lesion itself appears well circumscribed. I can see that there is like a capsule seen surrounding it. However, in my routine practice, I want to see the rest of the sequences, including the diffusion weighted images and
sequence?
post-contrast images.
Which sequence do you want?
I will start with post-contrast, then I will go back to diffusion and ADC map. Okay, this is a diffusion weighted image for the same patient. I can see that there is area of hyperintensity or high signal, which could represent restrictive. I want to correlate with the ADC map. In the ADC map, this corresponding with low signal, representing restrictive pattern, true restrictive pattern.
What's
And
your diagnosis,
now I want
doctor?
to see malignant lesion, and because of the smooth liver surface, I'm thinking about concept of cholangiocarcinoma.
Doctor, do you remember my history?
Yes, abdominal pain.
No. Fever.
Fever. Yeah. Okay, because of the constitutional symptoms
Doctor,
of fever and
doctor,
restrictive
one
pattern
second.
and fluid.
One second, please. Take care. Frankly, this is the next. This is the second time for you to forget the history and to give very far diagnosis. Just for you.
Yes.
Okay. Take care.
Yes.
What's your diagnosis?
Abscess collection.
What's your management?
My management is confine my finding to the referral doctor and transfer this case for the GI and interventional for drainage.
GI or surgical, doctor? What do you think?
Yes, surgical.
Surgical. GI here has no clue. Has no clue what he will do. The situation became surgical. Correct?
Yes.
Correct, my colleagues? I'm trying to...
Yes.
Okay, see, if I ask you why the abscess content show restricted diffusion, why?
Because it's high cellular. There is restrictive of the water movement within the abscess itself. This
What
was
is-
give the
What is the
restrictive pattern.
content? What is the content, please?
Content on the abscess, it will be bacterial, if it is bacterial, or يعني high cellular component, which cause restrictive movement of the water.
Okay, but still there are one buzzword. What is the content that makes the
Bus.
What?
Bus, containing bus.
Okay, what is the nature of pus?
Bus.
Is it water or something else?
Maybe another component rather than water, like high protein and low sugar.
Protein, the buzzword there, because abscess contain proteinaceous material. Proteinaceous material proteinaceous molecule are very large, so it has no free movement. So the movement here is restricted. So it give high DWI, diffusion weighted images, and the low ADC. What is low ADC? Low ADC values, because there are many values here. We saw it black, okay, but it may be measured. This is not in our scope. Okay, so any proteinaceous material. Doctor, could you describe another material that can show restriction other than abscess? Hello?
Metastasis.
Okay, but not metastasis itself. Not metastasis. Tumors.
Tumors, yes. Yeah.
Yeah, why tumors show diffusion restriction?
Because highly cellular component, such
Yes.
as lymphoma,
Yes,
for example.
One second. Packed cell. The buzzword in the tumors, packed cell. Okay? Packed. Packed cell. What mean by packed? Compressed cell. Okay? That is the cause, second cause. So, number one, abscess. Number two, tumors, especially يعني aggressive tumors, because it contain packed cell. Okay, doctor. What
Yes.
else? What else? What is the management here in this, according to this size?
It is large in size. So maybe there is a rule for intervention, and maybe there is rule for the surgical for drainage.
Okay, doctor. Thank you so much, my colleagues. It was a case of
Thank you.
Limbic abscess. Do you know, doctor, the name of the abscess, the bus here? It has very
Biogenic abscess.
No, this is amoebic abscess. Amoebic abscess.
Amoebic abscess.
What is the name of the pus? The gross pathology of the collection or the pus here. It has very specific name. Do you know?
I don't know. Sorry.
Okay, just to discuss. Do you know Ancusius? Because it is like very dark. Ancusius.
Okay.
Very dark. Some sort of very dark ketchup, but very dark. Okay, my colleagues. What is the cause of amoebic or abscess? What is the source, you think? Or what is the underlying mycobacterium? Hello?
Entamoeba histolytica.
Yes.
Yes.
So
it could be Entamoeba histolytica.
So then treatment must include metronidazole. Thank you, doctor, so much. We just
Yes.
we just searching in each way for any question, for any possible question that you may be asked in the exam. Thank you, doctors, for all of you. Let's meet tomorrow. Thank you, Dr. Nagam. Goodbye.
Thank you so much. Goodbye.
Welcome. Bye.